All right, so welcome to the November Health Policy and Bioethics Consortium that is organized by the Center for Bioethics. My name is Kesselheim. Leah Rand, who I'll introduce in a second, and I help organize this series. And we are pleased today to present a really great topic about how the Veterans Health Administration manages its pharmacy benefits and the lessons that would have for emerging Medicare negotiations of prescription drugs. So during the course of the talk of the introductory comments, please use the Q&A feature to list any questions that you have. If there is any technical issues, you can use the chat feature, but we're going to be screening for questions on the Q&A side, not on the chat side. So try not to put your questions there. Feel free to use the hashtag HMS Bioethics on the social media site of your choosing. And if you are interested in other events organized by the Center for Bioethics, you can check it out on their website. So the goal of the consortia series is to address key issues in the healthcare system that involve ethically challenging policies or practices, bring together experts with different experiences and expertise to consider or propose solutions, and to try to stimulate conversation and lead people to, think about ways of dealing with this topic or integrating issues related to this topic in their own work, whether in academia or government or wherever you are based. And here is a list. Again, if you go to the Bioethics website, you can see the list of upcoming events and consortia, including the ones that you can see here, and you'll get a better sense of the agendas for each of these meetings as well, coming up in the next few weeks. So for today's session, I'm going to turn the mic over to my co-organizer, Leah Rand, who is an ethicist and faculty member at the Center for Bioethics, and a research scientist here in the Division of Pharmacoepidemiology and Portal, with expertise and a lot of work in issues related to drug effectiveness evaluation, and trying to make decisions about which drugs are cost effective. So Leah, thank you for organizing and moderating today.
Thanks, Aaron. So I'm really looking forward to today's session because the big health policy topic of the year is Medicare price negotiation of prescription drugs. So the 2003 Medicare Modernization Act that created Medicare Part D, the prescription drug benefit, included a clause that prohibited the Secretary of Health and Human Services from conducting negotiations or being involved in formulary placement within any of the Part D programs. And this has meant that for 2 decades of its existence, Medicare has not been negotiating the prices for the prescription drugs it pays for its beneficiaries. And in 2022, after a lot of political tension and work to get this passed, the Inflation Reduction Act finally gave Medicare the power to begin negotiating prices for certain prescription drugs every year. And that'll be up to 20 drugs per year when the act is fully implemented. Now, since it was passed, there have been lawsuits from multiple pharmaceutical manufacturers trying to stop the implementation of this law, and a lot of debate about what it will look like to negotiate prices and what this means for Medicare and the American health system. In the midst of all of this, though, there is a federal agency that already negotiates its prescription drug prices, and that's the Veterans Health Administration. So the VA health system serves 9 million veterans and has a national formulary with a pharmacy benefits management service that makes decisions about statutory discounts, supply agreements, and what goes on to their national formulary. And there have been multiple studies that have shown significant savings if Medicare were to adopt prices similar to those used in the VA health system. So one, for example, from 2016 said that for the top 50 drugs in Medicare Part D, they would have saved 44% of their spending if they had used VA prices. And so in this national debate right now about what it means to have major health systems negotiating prices and the implications for a prescription drug market, innovation, and patient access, the VA provides an example where we can start to see what does it look like for a federal health system to negotiate prices and the implications for that market. So I'm really looking forward today to having this conversation and welcoming two experts in this area to join us for it. So starting us off is Chester Burney-Good, who is a professor of medicine and pharmacy and the director of the Center for Value-Based Pharmacy Initiatives at the University of Pittsburgh. He also serves as the senior medical director of the University of Pittsburgh Medical Center Health Plan Insurance Division. He formerly served as the chair of the Medical Advisory Panel for Pharmacy Benefits Management and the co-director of the Center for Medication Safety for nearly 20 years. So has an in-depth knowledge of the VA health system. He is a drug safety expert and has implemented innovative value-based contracts for pharmaceuticals. So we're looking forward to hearing his perspective. Following him is Inmaculada Hernandez, who is a pharmaceutical health services researcher and a professor at the University of California, San Diego. She's authored over 100 scientific articles and was recognized on the Forbes Under 30 list in 30 Under 30 list in 2018 and in 2021. She became the first pharmacist to be honored with the Academy Health Alice S. Hirsch Emerging Leader Award. Professor Hernandez currently holds the National Academy of Medicine Fellowship in Pharmacy, and she serves as an associate editor for Health Affairs Scholar. She is a fellow of the American College of Cardiology and the American Heart Association. So thank you both for joining us today, and I look forward to a good conversation following your presentations. And so as a reminder to the audience, please submit your questions through that Q&A chat box, and we will address them at the end.
So thanks, Aaron, and thanks, Leah, for inviting me to speak. I'm privileged and honored to participate in this discussion. I think it should be very interesting. And I also look forward to hearing Dr. Hernandez's comments. Next slide. So I want to start with a couple disclaimers. First and foremost is to mention that I no longer work for VA. I do go there as a volunteer, but I was employed at VA from 1986 to 2018, and I served as the chair of the Medical Advisory Panel, or the MAP, for Pharmacy Benefits Management from 1999 to 2018. So the MAP, or Medical Advisory Panel, is essentially the National Pharmacy and Therapeutics Committee for VA. So this presentation is based on my understandings and opinions, and as such does not represent the Department of Veterans Affairs, nor do my opinions represent that of my current employer. Having said that, I spent most of my career in VA and was directly involved in most of the things that I'm going to be talking about. So I do believe that they are correct. I also should mention that I have no relevant conflicts of interest. Specifically, I don't take money from the drug industry. You can check me in CMS open payments. I have no entries ever. My opinions, though, might be biased because of my prior employment at VA and my involvement in drug negotiations. And furthermore, I'm currently employed, as Leah mentioned, by UPMC Health Plan, which is a regional integrated delivery and finance system located in Western Pennsylvania. And again, I'm involved in drug negotiations here. Next slide. So I'd like just to touch on three things and then look forward to questions and answers in our discussion. I'd like to talk a little bit about the history of VA drug price negotiations, how we got there, discuss VA characteristics which are relevant to pricing. And I think it's quite important to mention those things as we look towards Medicare negotiations. And then finally discuss various forms of VA drug discounts. Next slide. So how did VA get to where it is with drug contracting? And I'll take it back to Dr. Ken Kaiser, who is an emergency physician who was named the Undersecretary for Health, the Department of Veterans Affairs in 1994. And he was tasked with transforming the VA to leverage its size and its capabilities into a unified and more efficient system. So the VA in 1994, when he came, was a large but fragmented care system where 90% of the patients did not have a primary care provider. There were 140 VA medical centers, each was their own entity, and there were many, many inpatient beds. Again, I was practicing back then, and there was a lot of I think, waste and inefficiencies at that time. Specific to this discussion, there was wide variation in drug formularies. So you could go to one VA and they would cover, they may cover essentially everything. And then you could go to another VA and they had a very, very restrictive drug formulary. And of course, that should never happen. If you're a veteran who's eligible for care in the VA, you should have equal access to drugs. So Dr. Kaiser began the consolidation of VAs, opened up community-based outpatient clinics, they're referred to as CBOCs, and they closed about 50% of their beds. And this was a national trend. A lot of healthcare systems were also doing similar things, closing beds and increasing outpatient clinics. In 1996, they formed the VA Medical Advisory Panel, the MAP, and this was for Pharmacy Benefits Management. And this was to develop a unified VA national formulary. The MAP consisted and still consists of VA physicians from across the country representing different specialty areas, VA pharmacy managers from every Veterans Integrated Service Network, that's VISN, and that just is VA regions. And there's 22 of them across the country. And then clinical pharmacy specialists and subject matter experts. For all of his work in VA, his renomination was blocked in 1999. He made a lot of enemies, including pharma, did not like what he was doing. But the wheels had already been set in motion and change in the VA continued after he left. And it was around the time that he left that we finally were able to consolidate the formulary into one national VA formulary, and that opened up the possibility of contracting for drugs. I would just say, without going into much details, we never got permission to do this. We just did it. And, later there were questions about, who gave us permission, and all we could do is point to all the savings and say it was good for VA. And since then, I think VA is recognizing for having, if not the lowest, among the lowest net prices for pharmaceutical in the US and possibly the world. I was part of an international drug consortium for most of my years in the VA, and we used to have annual and biannual meetings, and we were able to confidentially compare prices from all around the world, and our prices at VA were always significantly lower. Next slide. The goals of VA Pharmacy Benefits Management then is to first and foremost provide a comprehensive drug benefit to treat the majority of medical conditions for veterans. Second is to provide a standardized drug benefit across the entire VA. So as mentioned, before we developed the national formulary, there was wide variation in what would be available in terms of pharmaceuticals at different VAs. And again, if you're a veteran, it shouldn't matter if you go to the VA in Pittsburgh or go to the VA with the West LA VA in California. The access and the formulary should be the same. Along the same lines, utilize the National Electronic Medical Record to enhance portability of this drug benefit and to promote drug safety. So because there is a national electronic medical record, we have a lot of snowbirds in Pittsburgh, as an example. They spend their winters in Florida. Well, when they leave Pittsburgh and go to Florida, the VAs in Florida are able to see their notes from Pittsburgh and also to see what medications they're getting. And that promotes drug safety so that you're not, unintentionally prescribing drugs for where there might be a drug-drug interaction. Fourth, leverage the size and uniformity of the VA for pharmaceutical contracting. And I'll talk a little bit more about that in a subsequent slide. And then finally, manage the pharmacy benefit to identify best practices, benchmark, and assess compliance to the plan. And VA really has done a lot of that to really make sure that when there are drugs that are on the formulary, to make sure that they're being used appropriately. And I'm not just talking about overutilization, but more importantly, underutilization. So, and even though we have the VA has a national formulary and everyone must utilize it, if you look at utilization, you'll always find areas where perhaps an expensive technology is not being used as often as it should be. And that usually resulted in us investigating it and going out and finding out what the problem was. And oftentimes it would be a rogue either director or pharmacy director that was putting up barriers that were not supposed to be there. Next slide. So it's important to recognize that there are a number of unique characteristics of VA that are relevant to drug pricing. And I want to emphasize this word unique, because as we think about Medicare negotiations for prices, there are a lot of things in VA which are different than say in a health plan, insured plan, or in a federal federal group like Medicare Advantage. So VA is one unique national system which cares for about 9 million veterans. There are many hospitals, clinics, clinicians, but again, there's one VA national formulary and everyone must adhere to it. And because of that, the VA is able to move significant market share among therapeutically similar products. And this is what's behind the national contracting and the reason why VA is able to get very deep discounts for some pharmaceuticals. Another important part is that many medical trainees spend time at the VA, and thus they're exposed to the VA national formulary. Most recently, I looked it up. There are 113,000 trainees and 16,000 affiliated medical faculty. So if you think about it, if you're a drug manufacturer, and let's say there's 4 or 5 or 6 CGRP inhibitors for migraine, a common condition, and you want to make sure that most clinicians are not going to be using all of these. They'll get comfortable with 1 or 2. And so if you can get your drug to be used and on the national formulary VA, you have every year graduating a whole cadre of trainees that are going to take that experience and familiarity with your drug. And so this VA does use this to their advantage. Also importantly, there are no rebates in the VA. The price is the price. So there's no 340B. There's no Medicaid best price considerations, et cetera, et cetera. It's whatever the negotiated price is, that's the price for everybody across the VA. Another thing is there's no separation of medical and pharmacy billing. So, in Medicare Advantage, of course, the patient could be charged differently if they get a drug that's administered in a hospital clinic or a medical clinic, as opposed to picking it up at the pharmacy. There's none of that. There's no buy and bill. It's just, it's all the same in VA. So thus there's one set of rules. And so, I work now for a regional insurer, and, we have, lots of different lines of business: Medicare, Medicaid, health exchange, commercial, different types of commercial plans, SNP, CHIP, it goes on. And all of these lines of business have different sets of requirements and rules. But in VA, it's one unified system with one set of rules. And finally, VA has low or no copay for medications in VA. About 50% of veterans don't pay 50% of the prescriptions. There's no copay assigned to it. And that's either because they have a condition, an injury that occurred during their service, and so any subsequent treatment, including pharmaceuticals, is free for the rest of their life, or because of income, low income, some of them don't need to pay. Those that do have copays, the copays are fixed and are quite reasonable for most veterans. Next slide. So there's 4 major types of VA price discounts, and I thought I'd just mention them. The first is the federal supply schedule. And as you go from one discount to the next, you get deeper discounts. So the starting point is the federal supply schedule. So in order for any drug to be sold to the federal government, they have to be listed on the federal supply schedule. And to be listed, the manufacturer of that drug has to agree and negotiate a price. And that's done by VA contracting officers for the federal government. And then once a drug is on the federal supply schedule, it is available to any federal organization. Next is our big four prices. And so the Department of Veterans Affairs, Department of Defense, Public Health Service, and the Coast Guard, they are referred to as the big four. And they frequently get an additional discount above that of the federal supply schedule. And this can actually be significantly less than the FSS. This negotiated price is the so-called federal ceiling price, which represents 24% below the non-federal average manufacturer price. And it can even be negotiated lower. So that's the big four price. Additionally, there can be temporary price reductions or TPRs. And here, drug manufacturers can offer additional price discounts to the VA or I guess other federal entities. And these are called temporary price reductions. Again, these are voluntary and they can be ended at the discretion of industry. Usually these occur when there's a drug manufacturer that's hoping to encourage greater uptake of a particular drug within class. So when there's other drugs in that class and they're all covered by VA, they want to give some incentive for those VAs to encourage use of the least expensive product, and so sometimes can offer even additional discounts. And then finally is national contracting. And so the prices associated with national contracts represent the greatest reduction in cost for pharmaceuticals. One of the first national contracts, and I was involved in this, was for branded statins. So, now they're all generic or mostly generic and pretty cheap. But for a while, they were really big ticket item for most insurers and most health plans. So we did a national contract for a higher potency statin, and it pitted torvastatin with simvastatin. And I should note that cerivatastatin was also available as a higher potency steroid statin at the time. But we actually we made a determination that there were too many safety issues with cerivatastatin. And so we did not include it in the solicitation. We took some bad press over that decision. But ultimately, it was the right decision as the drug was pulled for the market in a year. However, that national, one of the earliest negotiations resulted in a really deep discount for the drug that actually eventually won. It was simvastatin, and it saved the VA many, many millions of dollars. And so since then, VA has negotiated hundreds of these national contracts, and some are very notable wins. And I would just mention, perhaps as one of the best examples, were when the hepatitis C drugs came out. And when they initially came out, we looked at how many patients we had, and we looked at the going price of these drugs. And if we treated everyone, it would have cost us over 20 billion with a B dollars. And our overall drug benefit at the time was about $5.5 billion. So it would have been impossible. So we did a lot of negotiating with the different drug companies. We had a number of options. And we were able to come up with a very aggressive and deep discount. And then because of that allowed VA to aggressively and successfully treat a large percentage of patients with hepatitis C, certainly more than any national average or any other healthcare system that we were aware of at the time. And so without those discounts that we achieved, we would have not been able to have treated nearly as many patients as quickly as we did, as there simply wasn't enough money to do so. And then finally, the last discount to be aware of is that prime vendor, that's where VA gets all their drugs. And we have a rapid payment. I'm no longer there. So VA has a rapid payment, immediate payment system. So as soon as a drug is dispensed to the VA, they pay for it. And because of that, they get an additional discount. And you might be surprised, it's a lot more than one might think. I don't know what it currently is. Next slide. So there are a number of considerations for how one might choose to do a national contract. First of all, presumably it's a somewhat prevalent disease. There needs to be therapeutic equipoise among treatment options, and there needs to be significant budget impact. If those conditions are met, the clinical staff at the PBM does an evidence review along with subject matter experts, and it's a comparative effectiveness of therapeutic options. And that report is presented to the Medical Advisory Panel for Pharmacy Benefits Management. If they concur that we should move forward with a national contract, that recommendation is made. A solicitation is made to all the relevant drug manufacturers, including the parameters of the solicitation, whether it's one drug or multiple drugs that will be included in this, and over what years. And then once the bids come in, VA contracting reviews the bids and declares a winner. Next slide. So one might wonder about, what are the actual VA prices? And like a lot of drug prices, VA is not able to promote what they actually pay. And so a lot of reports about VA prices are inaccurate because they go by the FSS price or sometimes the Big Four price. And recall that oftentimes there are a lot of other discounts in addition through either temporary price reductions and or national contracts. So perhaps the most accurate assessment of comparing VA prices that's publicly available was there's a GAO report in 2017, and they looked at 399 brand name and generic prescriptions, the highest, the drugs that were used the most frequently. And they, in order to compare prices, they used all applicable rebates in Medicare, and in VA, they use all applicable discounts. And so this, at the time, should be reasonably accurate, at least for those 399 used drugs. And as you can see there, 54%, they were 54% on average less than what was paid for in Medicare. And so that number is often bandied around as we could save, perhaps 50% if we did negotiations. Of those 399 drugs, about a quarter were at least 75% less expensive. And you can see here, this is a little table taken from the website from the GAO. And so all drugs, it was 54%. When they looked at the highest expenditure drugs, again, it was 54% less. Highest utilized drugs in terms of numbers, about 51%. And then the highest cost per use is 58%. So you get the point, is around 50%. Next slide. So I think there I'll stop and turn things over to Dr. Hernandez, and look forward to her presentation and then the questions and answers. Thank you.
Thank you very much, Dr. Ran and Dr. Kesselheim, for inviting me to be here today to talk about Medicare price negotiation. So how my talk is meant to be outlined is we will talk about how right now Medicare takes a market-based approach to drug pricing, in that insurers negotiate with manufacturers for discounts. And then that will be my first part of the talk. And then I will, on the second part, outline the main guidance around Medicare price negotiation. And I will try to make a point of how this is going to be different in terms of implications for patient out-of-pocket costs. This is meant to be a contrast with what VA is doing. And then I think in the Q&A session, we can, get engaged a little bit in more discussion of comparisons and how these two approaches may differ, how they may be differently effective at negotiating prices. I saw a question in the Q&A around that. So I think we will get in maybe in that more comparison in the Q&A. I did in the past, a few years ago, some scientific advisory consulting for Pfizer and BMS, more on the pharmacoepidemiology side. I have funding from West Health Policy Center for the work I'm going to be talking about today. And I would like to acknowledge that quite a few of the co-authors of the papers I'm going to be briefly mentioning work in the health insurance market. So as I said, I'm going to first talk about how Medicare is paying right now for drugs. And then we will talk about how drug negotiation will change the way how Medicare is paying for drugs. Now, Medicare pays for drugs slightly different based on whether the drugs are dispensed from the pharmacies, meaning a patient goes to the pharmacy to pick the prescription, versus provider-administered drugs, meaning drugs that are administered by providers in a clinical setting or in a physician office setting as part of or other services that providers may be delivering to patients. As Dr. Good said, in the VA, the approach to negotiation is similar. That's not the case here, but given the time that I had, I thought I could focus for now on pharmacy dispensed drugs, but happy to make any comments in the Q&A session around provider-administered drugs. Okay, so how is Medicare paying for drugs right now? Let me walk you through the flow of product and payment in the supply and reimbursement chain. So we have manufacturers selling drugs to wholesalers. That price at which wholesalers buy the drugs from manufacturers is the price, the list price, the price tag of a medicine. Pharmacies purchase drugs from wholesalers, and they are the ones that dispense drugs to patients from whom they collect out-of-pocket payments. If we think about a Medicare Part D beneficiary, they are enrolled in a Part D plan to which they pay premiums and also they pay taxes earlier on. And often Part D plans subcontract the coverage of prescription drug benefits to pharmacy benefit managers. Now, I will say there's a small exception, which is that in the Part D program, there's pharmacy benefit managers that actually also serve as Part D insurers because they directly offer Part D plans in the market without working with an insurer. So in some cases, these two entities may actually be represented in the Part D market by the same company. But the point is that pharmacy benefit managers reimburse pharmacies for the claims submitted. Often, independent pharmacies group in what we call pharmacy service administrative organizations, which are basically a group of independent pharmacies that negotiate contracts with PBMs, allowing them to get better rates than they could on their own. And this is how the other share of the claim is reimbursed back to the pharmacy. Now, importantly, PBMs negotiate with manufacturers, also in company of health plans, rebates in exchange for formulary placement. This is particularly the case for brand name drugs in competitive therapeutic classes, meaning if there's like 3 or 4 drugs that have a somewhat similar clinical profile, PBMs will come to manufacturers and say, hey, I need a 30% rebate to put you in the preferred tier of my formulary. Oh, you know what? Your competitor offered me 40%. You're going to have to bid that. And then pharmacy benefit manager share a share of the rebates with insurers. This is the system right now, how, I like to call it a market-based approach, in that actually the prices that are paid at the end of the day after discounts are based on the market. That this is negotiated freely by PBMs and manufacturers. In the past few years, this process has resulted in a big disconnect between the list prices. So the list prices are those price tags that represent the price at which wholesalers buy drugs from manufacturers. And that's represented by these crosses here. And you can see there's a big difference with the net price being represented by the solid part of the bars. The net price is the price that health insurers are paying at the end of the day after getting those rebates back from manufacturers. I have this example here for insulins. This is, for instance, for Humira. Maybe in the case of Humira, the trend is not as large as we saw for insulins, but it is consistent in that we see that over time, there's an increasing disconnect between list prices and net prices as PBMs are able to negotiate for higher discounts. I like to call this that this is a market-based approach to actual pricing. meaning to the prices that to the prices that insurers are paying after rebates. And this is in contraposition to list prices. We know from research we have done before that when there's new drugs coming into the market, this is, for instance, the case of drugs approved for the treatment of rheumatoid arthritis, you can see that when new drugs came into the market, the prices of the incumbent drugs did not go down. They actually increased faster. Another example to make the same point, this is the case of drugs used for multiple sclerosis. Once again, we had new drugs coming into the market. The list prices of existing products are not sensitive to that. That's not, however, what happens with net prices. So we did this year a study to figure out this point. Like, okay, we know list prices do not reflect competition in that when we have new entrants in the market, list prices continue to increase. But is negotiation happening on the rebate space? Meaning, is competition actually leading to changes in net prices? So to try to put some numbers behind this, we look at drugs that had competitive therapeutic substitutes coming into the market in the past decade. And then we did like an interrupted time series analysis to figure out changes in the trend, meaning the year-over-year change and the level of net prices after these new drugs came into the market. We found that new drug entry was associated with a 4.2% decrease in annual price growth, meaning on average, before drugs had competition, every year they went up by 6.5% in terms of net prices. So that is after discounts. However, once there was this first competitor into the market, the mean annual net price growth, the mean growth of which net prices went up was 2.4%. And in terms of the level in price, so not year over year, but what happened immediately to the net price, on average, we saw a decrease. Now, this paper has more results for specific therapeutic classes that I'm not going to go, but I just wanted to say this to bring the point that what Medicare has been doing now is a market-based approach to pricing, where rebates are the channel where negotiation is happening and where competition is having an effect on prices. What does this mean for Part D beneficiaries? So it is important to note that those rebates that we're discussing are not directly passed on to patients. What do I mean by that? What I mean is that the cost sharing, if patients pay, for instance, 25% coinsurance on a drug, that amount is applied on the list price, not the price after rebates. Let me walk you through a simplified example. In this example, I'm not accounting for profits to wholesalers or pharmacies or PBMs. I just want to briefly mention and make the point of what is happening to patients as a result of this widening disconnect between net prices and list prices. So let's say we had a drug that was priced at $100 in 2014, and this drug is taken by a Medicare Part D beneficiary with a 25% cost sharing. Therefore, the out-of-pocket payment was $25. And then the manufacturer was negotiating a 50% rebate with the PBM, which means that the manufacturer was giving $50 back to the PBM. And let me, assume that 95% of that was shared with the health insurer. Now I have been calculating here the amounts that each party could be paying. So the manufacturer would actually make $50 because the list price is $100, but they are giving $50 in rebates. The patient is paying $25, which is 25% of $100. The PBM is making a spread between the rebates they are getting from the manufacturer and what they are passing on to the health insurer. And here I'm calculating how much the health insurer is paying after the rebate they are getting back. What happens if in 2 years the drug doubles in price, but the rebate also increases? So let's say that now the list price is $200. The patient is now paying 25% of $200, which is $50, because as I said, the cost sharing is based on the list price. But the PBM is getting a larger amount because now it's 70% of this $200 amount and sharing back with the insurer. So in this case, the manufacturer is actually making $60 because the list price was $200, but giving back $140, and the patient is paying double. So if you compare what happened in this system, we have a manufacturer that doubled the price of the drug, doubled the list price, but as a result of giving more rebates, is only making 20% more. However, because the list prices is the publicly available information, they are taking the heat from the public, Congress, the whole thing, for doubling the price of the drug, although they are only making 20%. The patient is stuck paying twice as much. The health insurer is actually paying less, and the PBM is just doing great. And why I say that, in my opinion, this widening system that we have had between list prices being increasingly disconnected from net prices because of widening discounts exacerbates inequities in access. This is because, as I said, cost sharing is based on the list price, but rebates are passed on to beneficiaries through decreased premiums. What I mean by that is that premiums would grow faster if there hadn't been these rebates. So as a result, this system, the financial impact of this widening disconnection between list and net price is higher, or is higher for patients that have the least insurance coverage, are on like high deductible plans, uninsured. And also this financial impact of increasing list prices is also higher the sicker you are. Because again, the patients that are feeling the most impact on it are the ones that are going to pay the drugs in the pharmacy. If you have a generous health plan that doesn't have a deductible, maybe that has co-payments in fixed dollar amounts as opposed to proportions, probably the impact of these list prices going up is reduced because your premium is not going much up because the insurer is able to negotiate discounts. That concludes the part about how is Medicare paying for drugs right now. Let's talk now about what, in very basic terms, how is Medicare going to negotiate drug prices and what is that going to mean for patients? Okay. Medicare, the Inflation Reduction Act will allow CMS to negotiate prices of drugs that have the highest gross spending, meaning that they will be selected based on spending based on list prices without considering discounts. We're going to start negotiating 10 drugs in 2026. Those will be Part D drugs, meaning they are drugs that are dispensed from pharmacies, not provider administered. Eventually, CMS will also negotiate provider administered drugs, and then after 2029, the number of drugs will increase to be 20 per year. Drugs will stay negotiated until they have a generic or a biosimilar, in which case they won't be eligible for negotiation any longer. So those numbers will add up. First 10 drugs, then 15 on top of them, then 20 on top of them. Okay. The statute says how CMS sets basic guidelines for how drugs will be negotiated and sets a ceiling, meaning CMS cannot walk out of these negotiations with a price that is higher than this ceiling. The ceiling is set by the lower of two amounts. In terms of Part D drugs, is the current net price that Part D plans are paying after discounts. For Part B drugs is the average sales price, which also captures discounts. And the second part is a minimum discount based on how many years a drug has been on the market. Until 2030, the minimum discounts are the ones you have here on the slides. We did a little bit of research earlier this year, trying to figure out what is going to set the ceiling. And this list of drugs, I only have 6 out of the 10 that have been selected for negotiation because we did this research before the list of 10 drugs was out. So we did it based on our best identification of drugs according to the criteria. Now, because we have all the data, we were not able to identify 4 of the drugs that have had largest increases in spending and are going to be negotiated as a result of that. So with that caveat that here I only have 6 out of the 10 drugs subject to negotiation. So you can see that Eliquis is apixaban, a direct anticoagulant. Xarelto is rivaroxaban, direct anticoagulant too. Jardiance is a SGLT2. In those 3 cases, the net prices that party plans are paying are already below the ceiling. In the case of the 3 other drugs, that's not the case. The ceiling is going to be set based on the minimum statutory discount. This is an important point because manufacturers have, complained a little bit about these minimum statutory discounts. And we are showing that in many cases, the discounts that manufacturers are voluntarily, meaning they are not mandated, giving to PBMs are already way higher than the minimum discount, and they are giving them way earlier than the minimum number of years that a drug has to be in the market to be eligible for negotiation. That is, I think, one important point. Now, it is a bit hard sometimes to digest the guidance. So I've put together this figure for how I see in my mind a simplified approach to how CMS is going to be doing this. So CMS will select the 10 drugs, which we already have. Then they will determine whether those drugs have therapeutic alternatives. It's a bit unclear to what extent drugs need to be clinically comparable to be considered therapeutic alternatives, but I won't go into that unless anybody wants to ask in the Q&A session. If a drug is considered a unicorn in that there's no therapeutic alternatives, then CMS will look at the federal supply schedule or Big Four prices or the ceiling that I just showed you. And the lowest of those amounts will help set the initial price offer. It may not be the specific number because there's some other factors that are going to be used to adjust offers, but the range will be set by the lowest of the federal supply schedule or the ceiling MFP, the ceiling for the negotiated price. So this means that, there's something to learn from what VA is paying in this sense. Now, the assumption is that the majority of drugs will have therapeutic alternatives. In this case, Medicare will pull those therapeutic alternatives together. We look at the net prices, so how much party plans are paying for those therapeutic alternatives after discounts, and they will also look at relative clinical benefit. And this is inclusive of safety data, effectiveness data, patient-reported data, etc. Now, if the net prices of therapeutic alternatives are above the ceiling, CMS cannot go above the ceiling. Under no circumstance in the negotiation you can go above the ceiling. So if that's the case, once again, they will devote to the ceiling of the negotiated price or the VA price to set the initial price offer. The hope is that many drugs will fall actually in this category on the right, where there will be therapeutic alternatives, some with higher net prices than the ceiling, some with lower, and then CMS will have to do an integration of that net price and clinical benefit data into arriving to an initial price offer, which then will be adjusted based on other factors like unmet need, whether the drug has particularly beneficial effects for specific populations, how much manufacturers spend on research and development, what proportion has been recovered, what proportion of the research and development has been subsidized by federal funds, etc. But these other factors in the guidance are used to adjust the price offer that will be initially, range following the guidance that I explained here in this figure. Very important part for ethics. In integrating the clinical benefit and pricing data, CMS is not allowed to use data based on qualities because, as you know, that gives lower weight to increasing life gains in terms of duration of years for beneficiaries that are disabled, whose life expectancy is weighted at a lower quality adjusted life year. And there's also no implicit threshold for willingness to pay, meaning they are going to integrate the clinical benefit and the net pricing qualitatively, but we don't know. It's like, is 10% better effectiveness, 10% better price? Or we don't know how that threshold is going to be done because there's no implicit threshold to do this trade-off. It's going to be a qualitative integration. I believe this is my final slide. What is this going to mean for patients? First of all, part of the savings that are going to be generated by negotiation are going to be used to fund the implementation of a $2,000 out-of-pocket cap in Part D. The price negotiation may be the provision of the IRA that gets the most attention in the news, but it's not the only one, and it may not even be the most impactful one. That's subject to discussion. One of those other provisions is incorporating a cap, a maximum out-of-pocket threshold in Part D, which hadn't existed until now, and it's going to be $2,000. That obviously costs money, and partially the savings generated by negotiation are going to help fund this cap. So that's an important way how some beneficiaries, the ones that have very high out-of-pocket expenses, are going to benefit from negotiation. Now, importantly, for the drugs subject to negotiation, the cost sharing will be based on the negotiated price. So let's go back to my example. We had this drug with $200 list price, a 70% rebate, and we had the patient paying 25% of the list price, $50. Let's imagine, the hope is that this won't be the case, but let's imagine that CMS is not able to decrease the negotiated price below the current net price, which again, hopefully that won't be the case. At least now the patient will be paying their 25% cost sharing of the negotiated price of the $60, not the $200. So even if CMS was not able to decrease prices below the ceiling, which again, I don't think that's going to happen, at least patients will see an amelioration of out-of-pocket costs because cost sharing will be based on the negotiated price. This brings me to the end of the remarks I had prepared around how CMS Part D is paying for drugs now and what the negotiation is going to change. And looking forward to the Q&A session. Happy to talk about any other details I may have left out.
Thank you both. And so I see that there's some questions that have already come into the Q&A, and please do keep them coming as we go. So the question I wanted to start with is one of the arguments I hear the most frequently, which is a concern that when we negotiate a price or with something like a structured national formulary, that restricts patient access and choice. And so I was wondering how you see that concern realized, or perhaps how the systems respond to such concerns.
I'll start.
First?
So, yes, if you do a national contract between, I don't know, 4 drugs and you choose 2 winners, the physicians and prescribers at VA will be expected, for the most part, to prescribe those 2 drugs. So yes, you have less of an option. There are provisions that physicians and patients, if there's a compelling reason to use one of the off-contract drugs, they still have access to that, but they would require some sort of prior authorization or adjudication for that drug. The argument is that do we really need 9 ACE inhibitors or, 6 ARBs, or can't even remember how many there are. Do you really need that many? Or can you say, for the most part, I think what physicians actually usually do is they, they get comfortable with 1 or 2 drugs in a class and they use them. They don't use all the different SGLT2s. They get comfortable with 1 or 2, and that's what they use. And so, the contracting is sort of built on that principle. There are times when, when VA, and again, it's been 6 years since I've been involved in these discussions, but there were times when there were, very costly drug, drug classes, highly prevalent conditions, and we wanted to do a national contract. But what we heard from our clinicians was, if you choose drug A or B and not C, we can't go along with that, because we believe, even though the evidence shows that there's therapeutic equipoise, we think that drug C is better, and that's that's supported by the fact that the lion's share of the prescribing in VA, before the contract, is for that drug C. And so in those situations, VA has chosen not to go forward with a national contract because, we realize that, or VA realizes that it's not going to be supported, and physicians in that situation want choice. So I'm sure if you talk to, physicians at VA, most of them have gotten used to the system. But, obviously physicians want unfettered access to as many drugs as, whatever drug they want to prescribe. The reason to do it is, VA does not have an unlimited budget. They have a fixed budget. So if they spend, $6 billion on pharmaceuticals instead of $5 billion, or $7 billion on pharmaceuticals rather than $5 billion, which is probably more realistic, they're saving billions. Those $2 billion come from other things of patient care, or other things for veterans. So, every dollar saved, it's not like people who work for VA, that do these contracts get big bonuses. I can tell you they don't. So, it's to basically save money for the system. So it's a necessary evil, I would
say. There's been a bit of discussion on this on the Medicare negotiation side. So there was some concern from CMS that, for instance, if you have a class like SGLT2s, we have 2 negotiated drugs, non-negotiated drugs. PBMs would favor non-negotiated drugs because maybe those non-negotiated drugs could increase rebates to match the negotiated price. And we know that at same net price, PBMs will favor the drug with rebates as opposed to the negotiated drug, because the rebates allow them more flexibility. For that reason, there's some provisions in there that plans, and there's it's a bit unclear how they are going to enforce this, but plans are not allowed to disfavor negotiated drugs. And it seems that if they want to increase the tier in which they could need to ask CMS for approval. There's some discussion around that, because some believe that if we are going to negotiate those drugs, automatically they should be placed on preferred tier of the formulary in all plans, period. That's not what is going, what the guidance says. The idea is that CMS is aware of this concern, and plans, when they submit their formularies and their bids to Medicare, they will have to explain if they do anything that can be seen as disfavoring of the negotiated drugs, and that will be subject to CMS approval. But this is, I think, a point of contention.
Mm-hmm. Thank you. So it sounds both like the negotiation opens this opportunity to have the less expensive drug, but then also maybe like in exchange for having agreed to negotiate and accept this lower price, there ought to be good access then for the patients.
Right. I think it's a bit more complex probably on the Medicare side, right? Because I think Dr. Good said that access is good in the VA as co-sharing tends to be low. I think this is, as I said, one of the points of discussion in the Medicare side. I imagine we will learn, probably from the first year, the second year, of going through this process. We have two drug classes where this is happening now. The direct anticoagulants, we have Xarelto and Eliquis negotiated, not Pradaxa. But we also know that Pradaxa had the lowest market share. And then it does the same case in SGLT2s. But this may be the case again in other years. So I think it will be interesting to see first of all, what manufacturers of the non-negotiated drugs do, whether they increase rebates to match the net prices, then what party plans do in response to that, whether they really try or not to favor the non-negotiated drugs, and if that is the case, how CMS will respond. So I think there's a bit of uncertainty on that side.
Thank you. And that seems like one place where maybe this disconnect between who's negotiating and who's managing the formulary for Medicare stands out compared to the VA, which does both ends of that. So there was a question in the chat from Ben that I saw was answered, but I think is worth a little bit of conversation, which is what happens in instances where there's no competition between drugs in the same class. And so it becomes harder to, there's not a therapeutic alternative to compare or reference price to.
It's tough. So both in my, in my life in the VA and now outside of the VA, I've been involved in a lot of negotiations. If there is a drug that is a clear winner and has become the standard of care and has no competition, as a payer, we're in a very unenviable position, because we can't say, well, fine, you're charging too much, we're just not going to supply. In the UK a number of years back, even for drugs of questionable efficacy for treatment of dementia, they said, oh, they're too expensive, we're not going to cover them, and they got killed. We could never do that in the VA. We couldn't do it in my current position. We couldn't say, this drug, which is transformative for whatever the disease is, and it's the only one, we're simply not going to cover it because they want too much money. So they kind of have us over a barrel. Having said that, hopefully, people have, take a long game approach and realize that if you take advantage of your situation unreasonably, I mean, I think there should be reasonable expectations that pharma, gets, recoups their investments, and it's a world, it's a commercial world, so they should be able to make money and make profits. But if they go beyond what's reasonable, I think most payers will remember that, and then when they get the chance to stick it back, will. So hopefully these drug manufacturers will take a long game approach and say it's in our best interest, to work with these with these organizations. And in my experience, that's been the case. They're much less interested in giving deep discounts, deep rebates in the case of non-VA, or deep discounts in terms of the VA. You don't have a whole lot of tools in your toolbox, but clearly, you can, if you're a payer, you can regulate the use of that drug. So let's say it's a transformative drug. I mean, you can clamp it down so it's only used in those situations where it's most effective. And so you can tighten up utilization, and if they're more reasonable in terms of the price, perhaps you could be more lenient in your in your coverage. That's a sensitive thing, because you don't want to say people can pay their way to change your prior authorization or your criteria for use, whatever. So,
and I think that's one part in the negotiation is clear, Medicare negotiation, and I think that's actually that gives levers to CMS to be able to negotiate in those cases where there's no alternatives, right? So if there's no alternatives, is the lowest of the ceiling, which is based on that minimum statutory discount, because presumably the drugs that have no therapeutic alternatives, the ceiling will be based by the minimum discount and probably not the net price, because if no therapeutic alternatives, probably you are not going to see much discounting in the market. So you will look at that minimum discount or the federal supply schedule or the big four prices. So at least I think they will have some levers now that, as Dr. Good was saying, probably before Part D plans didn't have. So at least they will be able to get that incremental savings.
Thank you. And so, Dr. Good, you mentioned the NHS and the UK and that they make some of these decisions. And, in the US, we don't have, at least nationally and maybe within plans, bodies that are evaluating effectiveness and thinking about the placement of drugs on formularies. And you did give an example from the VA and your medical advisory that there was one statin, for example, that you decided not to recommend. And so there's a question here from someone in the audience about whether the US should be trying to implement some sort of similar kind of evidence-based formulary to recommend which drugs should be the easiest or the lowest cost for patients to access.
You would think that given the amount of money on the table, the United States could say, we're going to have an impartial, unbiased, scientific review, kind of like NICE or whatever, that looks at the drugs. But, something like that would be highly politically, it would be very difficult politically. I think the closest thing we have to it is ICER. And I personally think that ICER, I know that some in industry don't like what they do, but, sometimes they come out and support, they say, oh, the price of this drug is very, within the cost-effective range. So I think the closest thing we have is ICER. And I do think that, especially as time goes on, more and more payers are looking to ICER. I think, because they not only, I think their reviews are very sound. I think, their cost effectiveness numbers, I think, are very reasonable. They do budget impact. I think one of the problems is that, it's a limited organization, so they can't do every drug class, but it is pretty amazing how many of the big drugs that they've done. So, I'm personally very thankful for ICER and really appreciate what they've done. But, would I personally support such a national? Yeah, I think it would be awesome, but I don't see it happening, at least before I retire.
I think one point is that CMS is going to have to do part of this job for the drugs negotiated, right? So because they have to integrate the net pricing data with the clinical benefit data. So although they are not about the independent, like we are talking right now, part of the negotiation job is going to have to do that. So that's a bit of change. That they didn't used to do that for any drug. So now at least they are going to start doing it for more drugs every year. And I think it will be nice to see what lessons learned we get from that. Although, as we know, due to the confidentiality concerns on the negotiation process, I don't think it's going to be very transparent, that choice of comparators and that integration of evidence. So I don't know how, as a scientific community and country, how much we may be able to learn from it because of the confidentiality concerns around it. But I think CMS as an agency will learn from the process they have to do, and I hope that sets the precedent for other future work in the area.
And so since you raised this concern about confidentiality, one response that I sometimes hear when it comes to drug pricing and markets is the problem is that we just don't know what prices are and who's paying what and where there's profit being made. And so I'm wondering whether you think that transparency around prices and rebates and final negotiated prices would improve the system, solve the problem. Is that where the response or part of it lies?
I think that transparency is a goal in itself. I said that many times over the past 5-6 years when there was so much discussion in Congress and, all of these hearings where we came to realize that we really didn't know as a society where the money was going. And I have spent a big part of my research program the past few years to develop like an algorithm to track cash flow across the drug supply chain to figure out actually from all of this money unaccounted for, right, between the list price and the net price, how much is actually rebates that we are negotiating in the market versus 340B discounts or, discounts to Medicaid, etc. So I think transparency should be a goal in itself, and I think it's crucial to understand and reform the way how we pay for drugs. Now, I understand that in the setting of negotiation, the concern was that it is negotiation. It is not price setting, as sometimes manufacturers want to argue. It is negotiation, and I think as a way to preserve the ability of CMS to negotiate year over year, they don't want to fully publish this process that they are going to do to arrive at the initial price offer and further iterations as a way to respect the confidentiality and the ability to negotiate in the future, which I think it's reasonable. I think that's a little bit different, that piece of transparency, maybe from the piece of transparency in the drug supply chain, because it is meant to preserve the ability of CMS to negotiate to the greatest extent possible. And I think it's important to remind ourselves that as scientific as we are and as much as we like thresholds, this is negotiation. This is not what maybe the National Health Service in the UK is doing in terms of like we figure out, a threshold of quantities, depending on that, we make a decision. This is not that, this is negotiation. So I think in that setting, there's, one can understand the intent to try to preserve confidentiality in the process. Although, we are, as scientists, we are data monsters, that I say, so we like to understand how the process is done, right? And I would love to see what comparators they chose and how they arrived to the price. And I think that the field could learn a lot from it, and the country could learn a lot from it. But I can see how that may threaten the ability to negotiate in other occasions.
Dr. Good, I don't know if you have views on transparency in the VA system or.
Yeah, in an ideal world, things would be transparent. I can't talk about our negotiated prices at my organization. When I was at VA, we couldn't, and it was all, industry doesn't want us to release those prices. And I have to say that, when I was at the VA, I understood why we didn't want those prices to go up, because we feared that if everyone knew what we were paying for whatever the drug was, that then everyone would want that price, and other healthcare organizations couldn't do what we did at VA. We moved market share, and in my situation now, we can't move market share like we did in the VA. So, we could, if we're transparent, we say, hey, we got this price for this SGLT2, we got a 90% off of WAC. It's an amazing price. I don't think the drug manufacturers would be very willing to give us that price in future negotiations. I think in the long run, it would hurt VA, and likewise, in our own organization. I don't know what other health insurers are paying, but our concern was if we show our cards, then everyone wants the same deal, and maybe then that manufacturer's not willing to come with us on that.
And just for clarification, I did want to say that they will make publicly available the negotiated price, the final negotiated price. What will not be published is the process for how they got there. Yeah, just for clarification, in case my remarks were confusing.
So circling back to an example that was raised earlier was the Hep C drugs and the budget impact. And Anita has asked a good question about the new treatments for obesity. And this is like today's budget impact question, where every health insurer is thinking about how to cover and provide these drugs for all of the eligible patients. And so could you speak to utilization management, or is this a negotiation pricing issue for the rollout of these very effective but high budget impact drugs?
It's a great example. It's hepatitis C all over again, with one caveat. Hepatitis C, it's like Kentucky basketball; it's one and done. But with these obesity drugs, it's one forever. You know, you have to take them forever. So it's a little bit different. Of course, they're not as expensive as the Hep C drugs were, but given that 40% of our population, adult population, is overweight or obese, you know, the budget impact is crazy. The problem for every payer is that these drugs, we have a condition, a medical condition, which carries lots of comorbidity, results in lots of excess medical costs. And we now have 3 drugs. As of yesterday, we have 3 drugs that are FDA approved with the GLP and or GLP-GIP drug class to treat obesity, and they're very effective. People lose substantial amounts of weight. Yeah, there's lots of caveats, you know, about taking them, but it's you know, we have this situation where we have these highly effective drugs. In the case of Medicare, you can't cover them. That may change. There's legislation currently that's out there which says that, I think it's the Treat, I forget what the acronym is, but anyway, Treat Obesity Act. And so maybe, you know, Medicare will, and I suspect eventually they'll have to. And some state Medicaid organizations are covering them. So we're in Pennsylvania. Pennsylvania State Medicaid covers the GLP-1s for obesity. So we have a pretty interesting natural experiment in our state, and we're seeing lots and lots of use of these products in our Medicaid population. So what we're struggling with as an insurer is we have a transformative therapy that's very expensive with huge budget impact implications. And we have to be, you know, we have a number of, you know, we want to do the right thing for our patients, but we also have people that are paying for these products, you know, small businesses and things like that. And so we're in the middle of this. We're trying to figure it out. You know, my own belief is that what we'll have to do is somewhere along the line is figure out, you know, thread that needle to figure out who are the patients that, number one, are going to stay on therapy, because already we know that up to 40% or more people that take these drugs for obesity don't stay on for a year. I don't know why. Is it the copays or what? That I don't know, but a substantial proportion don't. So can we figure out who's going to be successful on them? Maybe it's that we need to support these patients better, have more wraparound care, more non-pharmacologic things to go along with the pharmacologic. And then figure out which patients are most likely to benefit from their weight loss. And it appears to be the higher the BMI. So you may say, even though people with a BMI of greater than 30 will benefit, you know, just practically, we're going to focus on a BMI greater than whatever, 35 or whatever it is. But it's a great example, and I don't have an answer yet.
On the Medicare side, we've written about this, and when Medicare Part D was enacted, weight loss drugs were excluded from coverage by the statute. So this is not CMS guidance. This is on the text of the statute, and this is very important because there may need to be legislative change to overcome this. And we recently wrote about this, trying to speculate whether CMMI could use its waiver authority to regionally test some coverage policies. But in the absence of that, legislative change would have to happen. We've written about this, and I think we agree that these therapies are transformative, and we believe that the arguments that historically, in the early 2000s made sense to exclude them from coverage do no longer stand, given the very strong clinical profile of these drugs. Now, the main barrier for coverage remains budget impact and the size of the population eligible for treatment. I think that given that probably legislative change is needed, we could think about more creative ways to allow party plans to cover them and maybe negotiate prices or try to figure out something else to do something about the price, right? Because now we're thinking of covering these drugs and we are negotiating drugs. So what if when Medicare Part D, when Congress decides that this drug should be covered and makes a law around it, maybe we could think about including something that the number of years needed to be in the market before negotiation that can be waived. So maybe we can cover them and negotiate them from day first. I think I agree with Dr. Go that I think the technical profile is very strong. I think eventually they will have to be covered by Part D. I think it's really hard to make an argument for lack of coverage once the drugs go generic, because the only thing that you could argue around it is the stigma of the disease. So I think eventually this will have to change. It's a matter of decreasing budget impact and ensuring financial sustainability in the short term before generics are available. One thing I will say related to a negotiation. Ozempic is most likely going to be negotiated in 2027 because of how the text is written. If GLP-1s for obesity were covered by Medicare, automatically Wegovy, the formulation of semaglutide for obesity could be automatically negotiated too, because the text of the negotiation says that they will negotiate all products for active ingredients within the same manufacturer automatically. That's the reason also why FIASP is negotiated at the same time as Novolog. So I think that's just an important point, that if Ozempic most likely is going to be negotiated. So if GLP-1s were approved for coverage, at least the leading molecules that already meet the criteria of number of years on the market in terms of active ingredient, they could be subject to negotiation.
Great. So thank you. This is clearly like a brewing problem that we will continue to hear about and be talking about. So Sean asked an interesting question that kind of gets at the political will behind these systems, and whether part of the reason why there's such distinct processes of drug negotiation is that it's just politically easier to give benefits to veterans and a smaller population. And so maybe what's been successful for the Veterans Health Administration won't be for Medicare. And Dr. Good, I don't know if you think that's an accurate characterization or want to respond to that.
I do think that drug manufacturers do view VA favorably. But I think that most of the time the prices that VA gets is because of hardball negotiations. But I can think of at least one situation, and I won't mention the drug class, but where the CEO of that drug company had a son who was active duty, and he felt a real obligation to and it was his drug company made a very important drug class, and he specifically mentioned it, and he said, I feel obligated to treat VA very favorably, but you can't tell anybody that we did this. So anyway, I don't know. I don't know. I guess we're going to see whether through the IRA, if these negotiations will be more successful and get lower prices. And you could think that because it's a much larger population, because they don't want to lose out if they get somehow squeezed out. And I don't know how that might happen, but you could anticipate that they might be willing to go deeper to get more of the market share. I don't know. So that would be one argument, but the opposite argument would be because VA is small. It's 9 million veterans as opposed to hundreds of millions of people, and you don't that your risk in terms of, your return on investment isn't very high with the VA, whereas if it's with all of Medicare, there are, so many more. So I don't know what the answer is. I think we have to see. I'm personally skeptical. I don't think that the Medicare negotiations will be as successful in terms of the bottom line, in terms of the net price. I don't think so. It's because, again, VA can move market share. VA is a teaching site. You get to, lots of interns and residents come through. They get used to your medicine. They go out and they practice. And I think drug companies put a price tag on that, and if you just do it for all of, Medicare, you don't have that, but we'll see.
I agree. I think the point about the closed system and the ability to move market share is what makes a big difference, right? Because it's very different as a manufacturer to come to negotiate with VA knowing there's other competitors than to come to negotiate with CMS because you got selected, right? Voluntarily. And also know that in VA, if you are not as part of the negotiated drugs, as Dr. Good said, there's going to be very low utilization as opposed to in the market, right? Where like PBMs, may actually be continuing not to favor you more than the negotiated drugs or not, but at least, you'd rather be on the non-negotiated position. So I think that makes a big difference. And I agree. I think I do not believe that Medicare negotiations will be as effective in terms of bottom prices as VA.
Right. So I've seen Aaron reappear, which means we're just about at time. Maybe in our one remaining minute, we've just ended on a pessimistic note. So the CMS guidance on how they'll do this process is still being written and finalized. And so is there one thing you'd like to see them adopt to make their program successful?
Man, that's a hard question.
One of many.
Whatever Inma says, I agree.
That's cheating. I think I would like, so I think there's some areas of uncertainty. We were trying to do a process about it. I think it's going to be interesting, the issue about integrating evidence across indications, and also how this issue of the favored versus non-favored drugs in the negotiated in those classes that are competitive. So I guess I would like to see maybe some more clarity, or I'm looking forward to seeing what happens once those bids go in terms of those classes, competitive classes with negotiated and non-negotiated areas. I think it's important for CMS to show a strong response there that they will not allow plans to disfavor the negotiated drugs, because otherwise that would kill a big part of the purpose of this negotiation. So I guess that will be my wish.
Thank you. And so thank you both for joining us today and for this conversation and sharing your perspective. I've learned, and it's wonderful to think about these two different systems in a bit more depth. So to everyone else, thank you for joining us. We'll be back the second Friday of December to talk about telehealth.